So the most common adverse effect is precipitation of the acute attack of the gout. And those individuals who are taking allopurinol, some individuals are associated with the hypersensitivity. So the group of individuals who are having HLA-B5801 are associated with the hypersensitivity with allopurinol. This allopurinol, when combined with the ampicillin, what is the problem is nearly around 20% of the patients develop rash. And another important point to be remembered is the dosage of the allopurinol should be reduced in patients with the renal failure. The dosage of the allopurinol should be reduced in patients with the renal failure. Whereas if you take febuxostat, no dosage adjustment in renal failure, but in patients who are taking with the febuxostat, we have to monitor the liver function test. The febuxostat is a non-purine analog. They act by inhibiting the xanthine oxidase enzyme. And the next group of drugs are drugs that increase the excretion of the uric acid. Here we have three group of drugs that are probenecid, sulfaperazone, benzobromoran, and these drugs are called as uricosuric drugs, and they act by the mechanism of action is they act as a competitive inhibitors. These three drugs, they act as a competitive inhibitors because they reabsorb of uric acid in the proximal tubule. These three drugs, what they do is they inhibit the reabsorption of the uric acid which is occurring at the level of the proximal convoluted tubule. If more and more uric acid, it will be there within the tubules or urine that gets excreted in the urine. But an important precaution, what are you doing by giving these drugs is you are not allowing the uric acid to be reabsorbed at the level of the proximal convoluted tubule. Now, increasing uric acid levels in the urine, so there is a great chance that there may be a formation of the uric acid crystals in the kidney at the level of the proximal convoluted tubule. So how to avoid this is, what we have to do is we have to advise the patient to take plenty of fluids and urinary alkalizers. We have to advise the patient to take plenty of fluids and urinary alkalizers concurrently to prevent the precipitation of the uric acid crystals in the kidney. Now, an important point you should remember is these drugs are ineffective in patients with the kidney damage, and the drug probenecid along with penicillin decreases the uric acid excretion. As we discussed, these three drugs are called uricosuric drugs because they are increasing the excretion of the uric acid. And here the important point to be remembered is these uricosuric drugs should not be used in patients who have a history of nephrolithiasis and in patients who have the evidence of increased uric acid production, and in patients with if the creatinine clearance is less than 50 ml per minute, this uricosuric drug should not be used. It should be avoided. This means whenever there is more than 800 ml per grams of uric acid which is being produced in the 24 hours urine collection, the uricosuric drug should be avoided in these patients because the chance of formation of the uric acid crystals will be more. Coming to the last group of drugs, these are the drugs which increase the metabolism of the uric acid. Now see here, uric acid whichever is being produced is converted into the allantoin in presence of enzyme uricase, and which this allantoin gets excreted in the urine. Here the uric acid is insoluble and the allantoin is soluble. The urate oxidase is present only in the birds but absent in the humans. We have here recombinant urate oxidase drugs that are rasburicase and pegloticase. Here pegloticase is a pegloticated drug because it increases the duration of the action, and these both drugs are administered intravenously and indicated in the chronic gout refractory to the other treatments. Thank you everyone.